Welcome to our webinar, Addressing Workforce Challenges and Keeping Patients Safer. So addressing workforce challenges and improving patient safety. And we're talking with CHS and how they've deployed the virtual patient monitoring. So welcome. Community Health Systems is one of the nation's largest healthcare companies. And the company's affiliates are leading providers of healthcare services, deployed and operating healthcare delivery system in 43 distinct markets across 15 states. CHS subsidiaries own or lease 77 affiliated hospitals with approximately 13,000 beds and operate more than 1,000 sites of care. So we're talking about patient safety and deploying something really at scale. And I'm excited today to have some key CHS leadership team talking about the process that they've gone through. So welcome, and I'm Elizabeth Retruba. I'm the Chief Clinical Officer from Avasure, and I will be facilitating. And we're here today with Dr. Lynn Simon. She serves as the Chief Medical Officer and has leadership responsibilities for healthcare innovation across the CHS organization. She's responsible for identifying and building innovative capabilities and creating better patient experience and improving care delivery and outcomes and streamlining workflow for clinicians, caregivers, and support teams. So this is right within your purview of what your role is. And I'm very excited to have my friend Pam Rudisill, who is a Senior Vice President and Chief Nursing Officer at Community Health Systems. And she is on some boards, on AONL, the nurses on boards, and she is responsible for nursing practice across those 13,000 beds that we were talking about. And also Ted Lomicka, who is the Vice President of Strategy and Analytics, who has played a big role in making this successful and strategically deciding about how virtual patient safety monitoring was going to be implemented and scaled. So thank you all for joining me today.
Thanks for having us. We're excited to share our story.
Yeah. So let's just start at the beginning. And you started implementing this in the middle of the pandemic. And I'm sure there were a lot of competing priorities in 2021. And so I'm really curious, what drove the impetus, and at what point did you determine we just can't accept the status quo any longer and had to address some of these issues?
Well, I'll start out. You know, we've been focused on high reliability and safety for over a decade, and have a strong patient safety organization. And so, you know, a lot of our thoughts about how to reduce harm and reduce falls really kind of continually come out of that, identify opportunities and look for ways to keep patients safer. So whether or not it's in the pandemic or otherwise, I know that you know, there are some specific challenges in the pandemic as far as, you know, people maybe, you know, not being in patients' room as often, et cetera. But we were on a path to try to look at how we reduce falls and keep patients safe, and really looking for a solution that we could deploy. So every health system has to deal with competing priorities, whether or not there's a pandemic. There's always, you know, issues to deal with. But I think we just sort of kept our eye on the ball and said, you know, it's time to really start looking for a solution for falls, and went searching for something that we thought we could deploy locally at some hospitals and then scale.
Good, good. And so then you kicked off a phase 1 implementation with Avasure across 5 of those markets. We had talked about your markets and 17 hospitals, and kind of had a phased in plan over about a year to implement them, and then at the 18-month mark then paused and reevaluated, and we'll talk about that. But what types of things did you take into consideration when choosing the right partner for this solution?
Yeah, well, we really started sort of with a pilot in one market with a few hospitals, and once we figured that that would work, then like you said, we moved on to that phase 1 implementation. But when we look for solutions, I mean, best case we find something that already has evidence behind it. And so we, in looking at partners such as Avasure to see that there was already an evidence base that the solution, worked, then, we can take that and say, well, will it work in our environment? So some things are difficult to plug and play, but it's always helpful to see something that has a track record that works. And then sometimes we just have to adapt them to our environment. It's not that we're against piloting things and seeing if they work, but it's really nice to start with a lot of evidence behind a solution and then see, can you adapt that? And so, we looked at, the solution, would it work in our environment? Is it feasible for us to put into our environment? Pam can talk more about the care team model she was creating and how maybe that was integrated, into that. And then, Ted helps us look to see if it's feasible from an economic standpoint to put in our environment. Is it something that we could not only do at, 2 or 3 hospitals, but as you mentioned, go to phase 1, look at it at, several markets and many more hospitals. And then is it, obviously, we want to make sure it's something that we can scale across the organization if it's needed in other hospitals and it's reasonable to do that. So that's kind of how we look at, whether we start with a pilot, go to phase 1, or go full scale. And you mentioned after 18 months, we did a pretty detailed analysis, and we like to sort of stop every once in a while and pause and say, are we getting the results that we intend? Because on the pilot, we saw, a dramatic reduction in falls, and it seemed to work very well. As we began to scale it, really wanted to see, could it work in other environments? And as it did, what were the actual results on patient safety? What are the actual results on, are we getting the return on the investment? Are we able to better utilize our staff more efficiently, et cetera? So to do that analysis and take a pause and say, are we getting the results that we intended to get? And then, yes, we are. And then we can check that box and move on. So I don't know if Pam has things to add.
I totally agree with things Dr. Simon said. And, with the workforce, I mean, we also really look at what is the satisfier for the staff. And we felt like with the sitter, nobody really, with the sitter, that's not the perfect solution. It was Avasure for everybody? No, but we did find, and what has been really interesting as we've gone into phase 2, I was telling Dr. Simon this morning, I mean, we've really got folks that are really coming up to the plate, really want to do this role, see the advantage of it, and happy. And that's what we want with the connection with the staff at the hospitals with it. You've got to have those pieces in place.
Yeah. It's kind of your approach is very unique. I mean, we're in 1,000 hospitals, and I've been here for 9 years, so I've kind of seen various approaches, and this made a lot of sense to me because, like you said, Dr. Simon, it was vetted, it's evidence-based. There's plenty in the medical and nursing literature to validate that virtual sitting is evidence-based and actually has more behind it than one-to-one sitters as far as the clinical evidence. But you didn't just dip your toe in. It was kind of like a pilot, but it was kind of a huge pilot. It's across like multiple, 17 hospitals. That's not what I usually think of when I think of a pilot. So,
well, I think the one thing, we did learn a lot. So I think when we did again, sort of that little smaller scale pilot, 2 to 3 hospitals, just a proof of concept more. And then, like you said, the phase 1 was fairly significant. But one of the things we really learned, and I think it was just, over time, things changed with the pandemic. There's just a lot of different dynamics, even within a year or two, as we're, starting to roll this out. But what we found is, whereas within a market we were creating local monitoring, we really found that we could leverage a centralized monitoring a centralized monitoring station or command center or whatever you want to call it, if you will, more to better capture the efficiencies and effectiveness of the overall system. So, we did change our approach because we had monitors for maybe one hospital of 6, monitor their own, and in a different market we had different monitoring. But when we took that pause and called time out and said, hey, how are we doing here? I think we decided as an organization, hey, we can centralize this and achieve the same results from a patient safety standpoint, but gain more efficiencies and more synergies as with monitoring in a centralized unit. So I think there are things that you can learn if you take very intentional about taking that pause and saying, are we achieving what we wanted to achieve and what could we do better?
Yeah. So after that, let's talk about that analysis that you did. It was actually earlier this year after sort of the first 18 months. And I also want to kind of set the stage for that, or put it in context, because you talked about high reliability and you talked about the challenges of safety that everyone was facing at that time. And so during the same time frame, just so when we talk about the outcomes that you had, there's to put it into context, pretty much everyone was not really winning that high reliability battle during this time. And just as an example, I'm going to bring out the Joint Commission data on serious safety events. So they published their annual report looking back at 2022. So we're kind of looking at the same time frame here, and of their Sentinel event data. And if you look at the falls and what you talked about, Dr. Simon, and we'll just zoom right into the patient fall Sentinel events that had happened from between 2020 to 2022. It is about patients being in isolation, staff being stretched. The doors are closed, so you don't know what's happening behind the door. Or if you think something's happening, you have to quick don PPE before you can get in. So not surprisingly, during this time frame, the Sentinel event falls increased by 253%. And so with that in context, so it was like you're looking at a fall prevention and patient safety intervention with virtual sitting during this same time frame. So tell us a little bit about the results that you found when you looked back across the 5 regional markets for the first 18 months on falls.
So we did see different results than you had showed. We had some hospitals that had up to a 76% reduction in their fall rate. So, not every hospital performed at that rate, but I think overall it was about 50% reduction in falls across those hospitals that were deploying the system. And then within 2022, the whole year, we only saw, we didn't see any, I guess, falls with serious injuries during that time. So it really was a pretty dramatic change. But, dramatic and not magic, we'll say, because Pam and her team worked really hard with the local facilities too, with adoption and trying to figure out what criteria and what we were going to use to the utilization percent we were trying to get to, because if a solution does not work if it's not utilized and not deployed on the right patient population. So Pam was very intentional with the teams about that. And once they're able to get up to a high level of utilization on the appropriate patients, that's when you saw the really dramatic change in the outcome.
When you talk about an overall fall rate decrease of, at some places, 76%, others 50%, not every patient's monitored. So that is about selecting the high risk fall patients and making sure. So the patient selection piece is huge. And then adoption of technology. When bedside nurses are like overwhelmed during this time frame, and now you're saying, during COVID, we're changing our policies every day about things. So the rate of change at the same time frame was huge. So Pam, why don't you talk a little bit about how did you lead during this time to really encourage the buy-in and the utilization in order to get to those outcomes as a nursing
Yeah.
leader?
It was, I mean, it's been pretty amazing actually with our hospitals that have adopted it. I mean, early on, it was brand new, and it was like we sort of had to revamp the what, the why, the who, and the how, and get that down to the frontline staff level to get their understanding. And I say frontline staff, but really the whole team, you know, from here with us all the way down through the chief nursing officers did a phenomenal job, the nurse leaders. But like everything, it takes consistency. So as Dr. Simon said, we had regular calls with the teams at the hospitals that have gone up on Avasure, and we still do. Talk about best practices, lessons learned, and then to develop our own tools. You mentioned, Elizabeth, about high fall risk. Was everybody aware in terms of leadership who was at risk for high falls, and how could that nursing supervisor support and go through and say, hey, this patient, is there some reason why we're not utilizing Avasure? So that's just one example, but it took a team, and it still does to this day take a team. But I can honestly say it is much easier now that we've tested it and piloted. Everybody, well, not everybody, most everybody wants calls daily us and say, hey, are we going to get Avasure? But as Dr. Simon said, it's got to be done, you know, with methodology to it, and what we've learned through our own system. But great teamwork, and that's what it took to get where we are today.
Yeah, I think there's phases you go through, right? You know, there's, you know, people get excited at first, and then after a while, they kind of want to go back to their regular business. So I think, you know, Pam's, my word of the year this year has been intentional, and Pam's been very intentional about this. But I think, you know, you have to be, and I think that to get people to adopt, you know, a new approach to how they do things, it does take effort, and it takes oversight, it takes leadership. So I think, you know, having all those components, it takes, you know, it takes getting the right metrics. What are your KPIs? What are you measuring? And then again, analyzing your results, and then, you know, kind of, you know, changing things up if you need to. So it was a very, you know, it was a very intentional and very, it was a process with a lot of leadership and a lot of oversight. So thanks to Pam and the nursing team for doing that, and the local hospital leadership as well. We're very appreciative of all of that as well.
I don't want to embarrass you, Pam, but I was visiting with you during this time frame, and you had daily emails. So you were aware of kind of the utilization, where the utilization was at in each market. And you're very fit, and you're always out running or walking every morning. And I guess that morning you had gotten a text from one of the chief nursing officers prior to the point when you got to your email. Can you tell that story? Because it's pretty funny.
Yeah, it was funny. It was like seeing the true advantage. I think the CNO was probably tired of hearing from me, so they actually thought, hey, are you up? I said, of course, you know, I'm always up, running in the dark. I had my phone with me, of course, though. But so they said, well, we're going to tell you right now what we're doing for the utilization and what we're getting ready to do, because we know you're going to be looking at those numbers that come up. And that's the true advantage too, is that our team here developed an easy form to where our whole team can look at moment to moment to see where we're at. And that helps not just to see the utilization, but to see with, you know, the staffing piece and where we are in terms of many variables. So
yeah, thanks. Ted, you've been quiet so far, but you've been key in this implementation and very close to it. And it's been great for me to kind of see your role. And so there was a measurable impact on patient falls. You were also able to redeploy staff back to work at the top of their skills and license and training. And you all undertook one of the most robust evaluations after that phase one, which we were part of, but than I've ever seen. But can you talk about a little bit of how you did that analysis from your perspective and what you found?
Sure, yeah, I'd be delighted to. So what I really find so appealing about the Avasure technology is it allows CHS and other health systems to have a really dedicated virtual patient monitoring solution that brings significant quality benefits. As we just learned, the CHS experience in our pilot is we cut the serious safety event-based falls in half, and that's very significant. A significant clinical benefit for the patients we serve. From a financial perspective, that's a lot of cost avoidance. And I'll share with you some numbers from our own research at CHS that really speaks to why we value this solution so much. When you think about that fall that happens and you realize that the patient is usually on a per case based DRG pricing, there's no incremental payment for the cost, the incremental cost of care if that patient has an injury as a result of that fall. If you look at some of the anecdotal research that some of the other organizations have done and published, you'll see when you do that you're talking somewhere at the low end that incremental cost could be around $2,500, or at the high end it could be somewhere around $16,000, depending on the severity of the injury and the added additional care that's required to provide help for that patient. So you're looking at an average cost of about incrementally $7,000 on average, direct patient care related for that. There is no incremental reimbursement for that. So that's all in the hospital health system. The other thing is when you have serious safety event falls, we live in a very litigious environment, and litigation is potentially a consequence. And so with that, if you look at an estimate for what a claim could be if a claim were to happen, put some numbers on that. I'll use some numbers for illustrative purposes. Let's imagine a claim cost of $100,000 and a probability of 8%. We'll combine that, that's $8,000. So you look at the $7,000 foregone reimbursed expense plus an $8,000 from a liability perspective, and you're looking at, when we avoid a serious safety event fall, a savings of $15,000 for each one of those events if we sought to quantify it as such. So that benefit is quite significant, and that's really an attractive aspect of this solution. The other thing you mentioned from a financial perspective is what Community Health Systems has used as an approach to really step in and avail ourselves to the workforce multiplier that we gain from the Avasure technology. Some of that is quite obvious, where you have the virtual patient monitor, the sitter, who's now able to view not just one patient, but up to 16 patients at once. So you're looking at a workforce multiplier of 16 to 1, which is quite significant. We noted that as we have an opportunity to scale that, we would be better off to scale it. We started with pioneering around our local markets, a local hub for the monitors, and we decided it would make more sense from an efficiency perspective and a staffing perspective and a dedicated solution perspective to have a one centralized monitoring solution. And so we're delighted to be standing that up now and having a lot of success with it. We know that's just another way for us to go bigger and broader across our organization and to be able to bring forth additional savings from this solution. The impact of that is significant. We have a quality initiative that will actually be profitable for the overall organization. So we're winning on many fronts here. The most important way to win is obviously on the patient care side, but the fact that we can deploy it in a manner that benefits the organization from the financial side is wonderful.
I'm sure. Go
ahead. One thing I wanted to add to that is, I mean, we're monitoring more patients and preventing falls in more patients than we would have been able to with one-to-one sitters. So I think that, whereas we dramatically reduced the one-to-one sitters and we're having better results from a variety of standpoints, as Ted said, more patients are being monitored and kept safe under this technology. So we wouldn't be able to do that if we were just using people at the bedside. So I think that's, there's so many different aspects I think you have to look at when you're looking at a solution like this.
Right, and I'm sure that there are many participants on the line wishing, like, I wish I had a TED. Pam and I
were very happy we have a TED.
Pam and I were in a leadership meeting with other system CNOs, and everybody kind of had that sentiment, like, oh, you know, just pulling all the disciplines. We got medical and innovation with Dr. Simon. We have nursing practice with Pam, and you're looking through the evidence, and the evidence, there is almost no evidence to show that one-to-one sitters are effective. It's kind of a tradition, an unproven tradition, and there's a lot of clinical evidence which has been vetted to show that the virtual sitting is safe and effective and even better. And then that allows you to build for your future, which is something that CHS is also leading on, just finding the right, like leading with care delivery. And you can't transform care delivery, you can't support bedside nurses if you're so short on nursing assistants, because they're all stuck in one-to-ones. And the turnover for that, the nursing assistant, the turnover is one of the highest in healthcare. It's well over 30%. So you need that to support your nurses so that everyone is doing what they're trained to do and what their license is. And you can't really waste that on something that's unproven. So I'd really like to hear a little bit more about kind of your big picture on care delivery in this environment, and tell us about your plans for what you're doing next, and maybe even incorporating virtual nursing into the mix.
Go ahead.
Okay. So Pam, as mentioned previously, has been on sort of a journey to sort of transform the care team model at the bedside. So having people work at the top of their license with a mix of both RN, LPNs, and patient care technicians. Adding, remote sitters or remote nursing to that is just another part of, how we're sort of trying to iterate kind of that care team at the bedside, both to, have better results from a patient care standpoint, but also find ways to better support the actual care team. So we think virtual sitting is part of that. I think we provided some evidence of that today. And then, as we think towards the future, we've done some small pilots of remote nursing with, I think, what a lot of organizations have done with admissions and, helping with the admission, helping with the discharge, helping support nurses, at the bedside. We haven't really sort of formalized or scaled that model, but we're thinking about, how might we do that? And then, thinking about other things, what can we do on a creative front as far as, wound care, remote wound care support, and other things. So what else can we do to bring expertise to the bedside that doesn't necessarily have to be at the bedside, can be remote, but can support that care team? So just some things we're thinking about future. And then Pam, maybe you want to add to that?
Yeah. I think, it was really coincidental in a sense that we did the Avoidance implementation. And at the same time, I mean, like every other system in the country, we're really looking for innovation to help with our workforce. And so the care team model came as a result of that. And I mean, the two of those combinations have worked so well in terms of care delivery, overall, our workforce, and as well as the falls, as we've mentioned earlier today. So I think it's just been a positive process. Is it perfect? No, the care delivery is not. I mean, I could go into a lot of details. We don't have enough of certain groups, LPNs and those kinds of things. But I think nationally, people are beginning to work with that. And certainly we are with our local markets as well, with different processes that we're putting in place.
Yeah, so I think we're at the very early stages of defining, what does nursing in the future look like? What can be provided, in a very feasible way remotely? So what parts of care can be remote? What parts of care are supportive? What parts of care at the bedside? And lots of other technologies potentially to talk about. But I think we're very early on in that journey. I think what we want to say is no technology or no AI is going to replace the human at the bedside. And so there's really no intention to do that. I think all these services and looking at different models of care are to be supportive of the nurses and the other personnel at the bedside to support the patient. So I want to make sure that no one thinks we're looking to replace humans to provide the very human care that is needed, in our hospital and health systems.
And just going on that theme of the very human care, we've been talking big numbers, big scale, I think probably maybe even intimidating scale to some people who might be listening who are part of a smaller organization. But let's take it all the way back to the patient. And Pam, do you have any examples of individual patient stories from implementing virtual sitting that kind of drive home that impact, that human side of it?
It's definitely a human side, even with the virtual technology. I get to go, fortunately, to some site visits to some of our facilities. And of course, going to the technology now is a big priority to see what's working, what's not working, and that sort of thing. So I was amazed at one of our facilities when I went, because I'm not one of those people that monitor and have that skill set that's needed to care for those patients, and was just standing talking to one of the staff and talking to the leader of the unit. And then we had the telesetters there, patient safety telesetters, and I was looking at the cameras, and there was patients, why they needed to be on the monitor to begin with. And the telesetter was talking to the patient, and just cool, calm, collected as that person could be. But the patient wasn't very cooperative at all. And so I kept thinking, okay, when we going to push that button, for the alarm? And it kept getting me. So finally, I guess I'm pretty clear as to if I'm nervous, I'm nervous. And so the telesetter, this was the first time I'd met him, but he knew my name, and he said, Pam, he said, let me do this. He said, I know what I'm doing with this patient. The point being, he had connected. We talked about connected care all the time. That telesitter had connected, knew that patient, knew what the limit was, and clearly was safe with what he was doing and what he was doing. So it turned out to be great, but it was a very, very positive learning experience for me. So now when I go, I try to reserve on the judgment of, put that light on.
And I think that expresses, you had said, I guess, when we say what is the differentiator, because I know there's a lot of different technologies out there, but it still is that human interaction, I think, that makes the difference. And I think you had said, I think on average, there's every 8 minutes, I guess there's a communication, right? Is that between?
That is correct. We looked at in the interactions about every 8 minutes that we have. And so
go ahead, Ted.
Yeah, sure. And so as we compared the AvaSure technology to some of the other technologies on the market, it's the human component that makes the difference. And so AvaSure is not just a technology, but it's a process. And so we have found that we can implement the process and have a significant, dramatic, favorable impact on patient care as a result. We know there are other solutions. We look at them. We actually have some other solutions. We really feel that the evidence supports that the AvaSure is, in fact, the best for generating the positive clinical outcomes, and it is driven by the human element.
So that, if they're interacting with a patient every 8 minutes, we think, it's not necessarily sort of seeing the risk of fall, like Pam said, looking at them, trying to understand, the movements or what's happening there that'll predict the fall. But I think it is that ability to interact with the patient that seems to make the difference. So again, as we gain more and more evidence, we'll see how that pans out. But right now, that's sort of our thinking is it's the technology and the human action, interaction that makes the difference.
As a nurse, I love that. Yeah. What lessons have you learned that you think would make it easier for someone who maybe they're starting to implement now, that you'd like to share? It's very generous of you to be here. and share your experience.
Yeah, I'll start out. I think,
Mhm.
everything has to start with, I think, kind of why. So when, we're talking with, caregivers or others, trying to have a shared understanding of why we're making a change, why we're piloting or trying or, implementing a change. So that shared understanding of what we're trying to achieve, so everyone understands the why, because in the absence of that, people make up their own reasons why something might be occurring. And so it's for patient safety, it's for quality, it's for a better patient experience. I think the why has to be shared very directly. And then I think, we sort of, I think in our environment, because of our scale, a lot of what we do is created by certain standards, around criteria or utilization. Those may change over time as we learn, and, we learn from hospitals and how they do things. But I think trying to create, some sort of standard or guidelines or expectation, like we talked about criteria, who would go on the system, who is best suited for it, who isn't, what are our expectations around utilization. And then, like I said, some sort of analysis to say, okay, we have expectations, we have, KPIs, are we meeting those or not? And, how do we analyze our results and maybe move forward? So those are my thoughts.
Oh, clearly my thoughts. And this has been a truly learning curve, but a great, I mean, it was Dr. Simon that started this whole process, and I was glad to get involved with it. But it has truly been teamwork at its best. I mean, it's not just nursing. I mean, Ted has been unbelievable with our team. And we've got, our patient safety officer of the company that's been extremely helpful, beneficial. Our whole regulatory has been part of this. Even plant ops has become so engaged. So it's just this whole teamwork that has made this what it really is today. And then the only other thing is something you've got to be consistent with it. If you let up on it, it's just like everything, patient experience or whatever, you got to have the validation with it to be able to move it forward and to keep it what it's supposed to be doing.
And I've observed you, Pam, really working with the chief nurses in the various hospitals, and I think that's a key position to be engaged and to be accountable for it. So, Ted, you've been close enough. I think you probably have some lessons learned.
Sure, yeah. I mean, lessons learned in terms of our, our Abashur experience. From the onset of the initial deployment of the solution in our pilot markets, I thought this was an interesting lesson learned. The question the nurses have is, who is that behind the camera? And so the solution is, it's us. And we did that by having the nurse techs would rotate in, they would do their clinical shift, and they would do a shift on the Abashur as a monitor. And so we knew who it was us. And so that gave us the comfort level. And so it didn't feel like Big Brother is watching, it felt very comfortable. And so organizationally, it helped to build that trust. And then that what happened before we saw the results. We see the results, we know what it does, we know how it fits in clinically. And that allowed us to then be able to centralize it because it's a trusted solution. So in terms of best practices, I think that building that trust among the nursing staff as who is that behind the camera?
Very good. Yeah, building the trust. And I think the slogan that I'm going to take away is the results were dramatic, but not magic. I love that. And I'm very excited. I think it's October is the target for centralizing this. And I don't want to say the numbers wrong. So, and I think Ted's the numbers person. So how big is that implementation going to be at the centralized?
Yeah, sure.
Yeah.
So I'll give you a little flavor for that. So, we started and we really got very acclimated with the solution with 15 hospitals, 87 devices. And so we looked at it, it worked, it's successful. And now we're in the process of expanding it to an additional 12 hospitals with 78 devices. So that footprint looks like 165 devices in 27 hospitals. It's really an exciting opportunity for us because if you look at the scalability of it, we just run the math on it, 165 Avasure devices, and with that 16:1 ratio, we would have 10.4 dedicated stations. We'll add a few extras so we have that necessary redundancy, and then we staff to it. So we're having a lot of fun. We had a very successful nurse recruitment within the last, a sitter recruitment within the last few weeks. We found a lot of interest, and so we swallowed for that. So we're putting that team together quite quickly. Very excited to move into the next phase where we have that centralized command center. We were able to hire somebody who has a lot of fantastic expertise in this area, and so we feel very confident in the solution going forward.
I'm excited for you too. And so I just want to thank you all for, it's very generous of you to share with others what you've learned. It's going to make it easier for others. And so thanks for that. And just remember, it's dramatic, but not magic. So thank you all.
All right, thank you. Thanks for the
Thank you
opportunity.
very much.
Yes. I think we have a final slide just to show the upcoming in-person symposium, which would be our first in-person here in Grand Rapids, Michigan, which is a lovely place to be in the fall. And we haven't been able to do that since pre-COVID. And so we're in 1,000 hospitals, and we just love to kind of create a platform like today, but in person. So then you can go find that person over lunch and pick their brain more, and it's just a great learning, sharing opportunity that we like to just kind of set the stage for that and then let it happen. So thank you all. Have a great day.
Thank you.
Thank you.
Thank you.